Hey, so in this video, I'm going to go through a couple differing approaches to reporting an MRI of the total spine with and without contrast, or an abbreviated total spine protocol for the evaluation of acute cord compression. So this is a pretty niche exam type. Basically, a total spine MRI is something that a clinician can just order, and it does a combined cervical, thoracic, and lumbar. At our institution, we currently do like a two-station, so it's kind of like the spine is split into two areas. We used to do a three-station, but it's the way that we do it is kind of more like a screening sort of thing. And among our indications are, well, let me just bring up our default template to show you to begin with. Among the indications are looking for like spinal infection or like anywhere in the spine, to look for or evaluate or track spinal metastatic disease, or kind of like complex, multi-level spinal trauma, overlapping any of the previously mentioned. So this is what our default template looks like. As you see, it has a section for the cervical spine, it has a section for the thoracic spine and the lumbar spine. As far as I see here, there's only there's some kind of like prompts to talk about, extraspinal, prevertebral soft tissue here, and I think this is the non-contrast. This is without and with contrast, but this is actually, but this impression actually probably needs to be changed. This is our default. This could be improved probably, but as you can see, it's pretty long. It kind of prompts you to talk about individual levels, even though truthfully with our protocol, it's kind of hard to see. The individual levels can be are a little bit more limited when evaluating disc spaces. Oftentimes when I have fellows or trainees reporting using this template, they provide a lot of detail that is not really going to impact management. A lot of times we're doing these on patients with really advanced, kind of really diffuse metastatic disease, or they have like bad metastatic disease or bad infection superimposed on chronic, a lot of degenerative change, multi-level spinal stenosis, and there's a lot of wording spent on the minor, mild spinal stenosis here, neurofilament here, that's often not well, here at that level or this level, that's often not well seen. It doesn't impact management. So especially in the setting of kind of patients who have like fairly extensive and complex pathology, where the real focus is on the metastatic disease, and we're really looking for, actionable things. We're talking about worsening metastatic disease, pathologic fractures, new epidural extent of disease. If we're talking about a focus of spinal infection, an intraspinal abscess, an epidural collection, prevertebral collection, those sorts of things, I tend to try to use a more clinically, or let's just say an actionable finding sort of approach. And so let me just show you what I use. Let's see. So this is my template. So basically, instead of breaking up the total spine into three different areas to talk separately about the cervical spine, and then the thoracic spine, and then the lumbar spine, I treat the whole spine as a single thing. And basically, I just talk about, instead of saying, let's go back here. So here, each section talks about, is there abnormal enhancement here? Is there, let's take a step back. Is the alignment okay? Are the vertebral body heights okay? Are the disc spaces okay? Is there abnormal enhancement? And this is repeated each section, right? So in my template, I basically just talk about the whole spine. Is there, anything acute? Is there acute traumatic pathology? Is there, anything concerning for suspicious marrow lesion? Is there any other spinal enhancement, right? And then what I found when I was a fellow and a junior attending, I usually said the same things. If you're trying to paint in broad strokes, I've got a line for the cervical spine, a line for the thoracic spine, a line for the lumbar spine. I've come to realize that when I did these a lot as a fellow, I said the same things all the time. And so I basically took the things I said most commonly and I like created a template around that. So typically I would say, if I was painting in broad strokes, I talk about, the cervical spine has like differing contributions. Usually it's these sorts of things. Sometimes I'll add and uncovertebral joint hypertrophy, blah, 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 and I give like the worst level, right? And then oftentimes with our protocol, the nerve foramen are not well seen, but if they are, then I will say, however, their suggestion of up to blah, 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 degree of stenosis, worse at this level. And I basically just try to describe the worst areas or the areas that are sufficiently bad or that correspond with patient symptomatology that are like either explanatory, actionable, or they you can do something about, or they're meaningful. I try to minimize talking about things that are going to be, of not that importance, especially if we're working, if we're in an acute setting, especially if we're trying to, sometimes, let me just say, sometimes less is more. You can confuse the picture if you add a whole bunch of stuff, and you can kind of get lost in the weeds. So at least that's my perspective, and that's kind of how I work. And similarly, frequently this statement is true for when we do these, and if not, then I'll modify. And then similarly, in the lumbar spine, most degen is produced by dysbulges for arthropathy, and sometimes we'll add ligamentum flavum thickening, epidural epitosis, et cetera, et cetera. If there's extra extrusions, and then I'll provide like the worst level. If there's multiple levels that are pretty bad, then I'll add that. And then I give, I just give like the worst areas, or like the worst and the bad areas, right? And sometimes I'll just delete this, and if they've got prior imaging that's similar, I'll just say, they've just been imaged like yesterday. It's just like the degenerative changes in the spinal stenosis aren't changed compared to yesterday, or exam yesterday, or if there's none, I'll just delete all this and say no significant spinal stenosis is seen, that sort of thing, right? And then as I've treated kind of the spine itself, right, and then the kind of broader, the broader strokes of degenerative change, those are kind of like major sections in this report. Then I've kind of talked about the intraspinal compartment, and where the spinal cord is, the thecal sac, key pertinent positives and negatives, right, and then the extraspinal anatomy, and this is a prompt. And this, again, I'm treating the whole spine as a unit. I'm talking about, anything that is outside of the actual spine. So we're seeing kind of the incidentally imaged brain, the facial soft tissues, and then all of the prevertebral, paravertebral soft tissues all together, considering them all together as a unit, and just being kind of try to be brief and focus our attention on the thing that matters the most. And truthfully, this is not that good a template. This could be further improved. There are no pick lists involved. There are actually, there's a couple, but like there's just like a lot more that could be done to spruce this up. Sometimes I'll delete one of these lines, some I'll just delete and I'll just replace. But I found that trying to narrow what we do and what we talk about is pretty reasonable. So this is a with and without. I think that here I've got a with similar, except it's just remove the this is a without contrast thing. And then there's another version which is even more kind of pared down. So we have an acute cord compression protocol, which basically does limited sequences. I believe it's like a sagittal stir for the whole spine, axial, T2. Really you can't see the nerve foramina well. It's can't really evaluate like the marrow signal, because I don't think we do a T1 with those. So we're basically, there's just like, this template that I have really just focuses, there's some inbuilt caveats, it says that we were using the abbreviated protocol, and it's literally just the pertinent positives, right? Certainly when I'm working on this, and I'll add things like, multi-level degenerative changes produce up to mild, spinal stenosis. This suggestion of, I might delete this and say those suggestion of mild nerve foraminal narrowing up to this, if I see it, blah, blah, blah. Talk about some, whatever, the caveats, the nuance, etc. But I'll use this as like kind of a baseline to, talk about some of the stuff, but I'm really providing the pertinent positive negatives. I'm telling the clinicians the key things that they really want to know, and if we really need to go further, they can get like a really dedicated, MRI of the lumbar spine, of the thoracic spine. They can get a full protocol and get with and without contrast they want. You know what I mean? But this is here to answer the fundamental questions that matter at that time. Okay, so I've really come to find that how the template, the tools you use make a huge difference in the readability of reports. They make a huge difference in the efficiency of reporting, and frankly, the ability to handle the list. I see this every day with our fellows, with with the colleagues who have spent more time in trying to invest in that tool set. I think it's a big deal, and for people who are nearing the end of training or who may work in an area, may be thinking about spinal, or like total spine, or kind of any sort of spinal reporting is going to be a part of their practice. I would have you kind of consider, if any of these tools will be useful to you, and if these sort of strategies will be useful. And of course, again, caveats, how you report and what is going to be important for you to provide for your referring services. It's going to be context specific. Your referring clinicians may want a certain style. They may want certain structured fields. They may want a certain degree of detail, and that's going to be a conversation between you and others within the system that you're a part of. So just some food for thought, and I would encourage anyone who is interested to try and be thoughtful, try and be intentional about the tools we use and how we approach consulting on any sort of case, especially these really large, complex studies where if you don't have a really thoughtful approach, you're going to get bogged down for, remember as a fellow, seeing colleagues, seeing co-fellows when I was in training, spend half an hour, 45 minutes on some of these where you really could be turning around 2, 3, 4 times faster if, we spent less time talking about things that really aren't going to help the patient. So, something to consider, something to think about. All right. And I hope this was helpful to you.